I do spend a couple months a year at UAB doing clinical work, and I have one project in Alabama working with Van Nyaim from your own School of Public Health and several other folks from the School of Medicine doing a project on HIV. And I hope I'm coming through clearly. But most of my professional work is in Africa, and so I also spend most of my personal time there in proximity to my research sites. And I also do a lot of more training and collaboration in that area. But that being said, I'm a very flexible, open collaborator and mentor. So if anyone's eyes are opened by my talk and they want to try to work together on anything in this arena or others, please reach out to me. I'm very available. So this might be different from your typical epi talk. I won't, as I'm not a methodologist like many of you, I won't try to describe deep methods for analyzing data and modeling different issues. But I thought that because I've been spending a lot of time setting up this new research network in Africa, I thought it might be interesting for you all to just get some insights from that. And I think some of the lessons that I have learned and that our network has learned would also be relevant, I think, to some of what you all are doing. And I think for me, it's really the first time that I got involved in starting something that's getting pretty big from the very beginning and with very little resources. So it was interesting to see how it's turned out. So thank you all, and I'll try to check in the chat box in case there are any questions from those who are zooming in, or otherwise someone can interrupt me if there are any questions. So we're going to be talking a lot about hepatitis B virus, and so I would be remiss if I didn't give you a primer into that, because I'm sure that many of you are not clinical doctors and nurses, and you may not have a lot of knowledge about that infection. So let's get started there. Yeah, so if nothing else, I hope you come away with a little bit of knowledge about this important global infectious disease, which is very neglected, even in the US. So hepatitis B virus, it's a very old human pathogen, and it's a DNA virus, which is more stable outside the environment than other viruses and can spread person to person in different ways. It can spread through percutaneous routes, through needle sharing, injection drug use. In low-income countries, can spread occasionally through unsterile procedures. And in the older days, it could spread through blood transfusions. And it can also spread sexually, and it can also spread mother to child. So it's overall, it is very well adapted to the human body. And it's estimated that 2 billion people out of, I think there are 5 on the planet, have some marker in their blood that they've had exposure to this virus. And worldwide, there are 296 million people living with the chronic form, and that's about tenfold more than HIV and more than hepatitis C as well. So you can see it's a major worldwide infection, and it results in about 1 million deaths per year due to complications of liver disease, because the virus has tropism or specific infection inside of the liver, and that's where the disease occurs. But unlike some of the other major infectious diseases, I'm thinking about tuberculosis, HIV, hepatitis C, we do have a vaccine, and it's been available since the 1990s. And so hepatitis B won't be as much of a problem, in 50 years from now, but we currently have a huge burden of infection, and most people feel strongly about acting to eliminate it rather than just waiting for a couple generations when we should have fewer cases because of the vaccine scale up. So this is the status of global elimination. Oh, this is elimination is a growing topic with international stakeholders like the WHO, but also the NIH and domestic stakeholders like CDC are pushing elimination. because we have the tools necessary. And so much of this is really an implementation challenge. So you can see here that Africa in the middle has 82 million individuals with chronic infection. And that compares to other regions. Southeast Asia also has 60 million people living with chronic infection. Western Pacific region, 116 million. So this is mainly an Africa-Asia problem, if you will. And the modelers, the mathematical modelers indicate that, as you can see in the darkest green bar, if we do nothing else from 2020 onwards, this is when this was published, we should see a slow decline in the number of infections represented there on the left in terms of global infections. Oh, sorry, that's the dotted green line. The dotted dark green line. You should see a slow decline in the prevalence. However, because of the aging population globally and new cases, we would expect to see an overall increase in the number of deaths if we do no further interventions. And so these darker solid lines are the targets that have been agreed upon by a lot of international stakeholders and also some national and regional policy groups and governments to improve testing and improve treatment. Because if you diagnose someone, which is relatively straightforward, and you treat them with current medications, you can avert many of the deaths from hepatitis B. But we have a long way to go. This is at the end of 2019. So you could see, even if you look in the Americas, the third group there, only 18% of people living with chronic hepatitis B were diagnosed. And in Africa and in Southeast Asia, it's as low as 2%. So this is the context in which I work, where we're diagnosing people all the time with chronic hepatitis B. And then in addition to having a low diagnosis rate, treatment is also very low. So only 0.1% of people with chronic hepatitis B in Africa are thought to be on treatment. And this slide is from a recent presentation from the WHO, Funmi Lesi, one of the focal people there in Geneva. Compounding that, another challenge that we face in Africa and what motivated us to start the Net was the fact that since Asia has a high burden of infection and also a lot of great technology and experience in the scientific realms, they have really led the way in hepatitis B research and knowledge generation. And so, for example, there's one cohort study which has an outdo influence in the field of hepatitis B. It's called the REVEAL HBV Cohort Study. This is a natural history study, and it began in 1991-92, where in Taiwan, 4,155 adults recruited through community testing were enrolled into a prospective cohort, and they collected consent forms, and then they followed them up every 6 to 12 months for blood tests and clinical evaluations. And they managed to follow these individuals for 12 to 14 years, and were able to accrue a lot of different hard outcomes, such as cancer incidence and all-cause mortality. And overall, they had about 40,000 person years of follow-up in this cohort. And this data set and the stored biomarkers and stored samples that they have subsequently used to analyze a lot of different markers that have evolved over time, this cohort has really led what we know about hepatitis B and has helped us to identify the risk factors for liver cancer in people living with hepatitis B, the risk factors for cirrhosis, and informed our thresholds for when to start treatment. So hepatitis B is also a slightly odd infection. I'm an infectious disease doctor, and I can think of very few infections where we diagnose the infection, but we do not treat it with antibiotics or anti-infective agents. But in hepatitis B, we typically, based upon the data from this cohort and multiple other mostly Asian studies, we generally only initiate treatment when we see a certain degree of liver disease develop, or when the viral load goes above this 200 threshold, which, as you can imagine, was feels a bit arbitrary, but is grounded and somewhat into cohort data. And so these are now dogma in the field of hepatitis B. As we're now, as I'm getting more involved in this field, we recognize that these dogmas that we shouldn't treat people are not always well aligned with what people living with hepatitis want. And also, it harkens a bit back to the HIV field, where in the early years, we used to wait until the immune system was damaged before we would initiate HIV treatment. And similarly, we wait in hepatitis B until there are liver damage before we initiate treatment. So it could be that there's opportunity to move the needle in this field and treat more patients. But that would need to be data driven because generally, you know, it's not enough for patients to advocate. We also need to have scientific rationale to expand treatment. Another angle that has really captured me while working in Africa is that, as I mentioned, almost all the data, I'm speaking like 95% of the data we have in hepatitis B was either generated by Asian cohorts or Asian research studies or among Asian individuals living outside of Asia in Europe or the US. And what we have seen is that in Africa, there's potentially a different disease occurring. So I'll start in the bottom. So what we see in the clinics looks different somewhat to what is reported in Asia. So there's a marker called the hepatitis B E antigen, which is a marker of replication of the virus. And in Africa, this particle is shed by the virus, and the virus evolves or mutates to stop producing it in the 3rd to 4th decades. Actually, this should say, yeah, okay, should say the 2nd to 3rd, sorry, 2nd to 3rd decades of life. So teenagers or in your early 20s, this happens. Whereas in Asia, it happens much later in life. Also, in Africa, we have seen a strong correlation of liver cancer at a very young age, especially in men. So actually, even in the US guidelines for hepatitis B, it indicates that if your patient with hepatitis B has African origin, that they should initiate cancer screening at a very young age. And then third, typically we see lower viral loads and lower levels of liver inflammation in Africa compared to Asian cohorts. And so things look a little bit different in the clinics, and these are some possible reasons. So the virus may be different. So there are actually unique viral genotypes in Africa that are not really transmitted or spreading in other regions. There are also some environmental promoters. So khat is a plant that is chewed in the Horn of Africa, and it can promote the acceleration of liver disease and can augment liver disease in people living with hepatitis B. And similarly, aflatoxin is something which it's a mold that can contaminate foodstuffs, primarily maize, and can also propagate liver cancer. Then in Africa, we also have a lot of co-infections, including HIV, which you will know about, and schistosomiasis, which is a parasitic infection in the liver. And then there could be host genetic or epigenetic differences that are underpinning these differences in the clinic. So for all of these reasons, we wanted to create data that can inform more Africa-centered policy in the field of hepatitis B, and also to build research capacity. And so together with a bunch of colleagues listed here on the right, we formed what's called HepsaNet, so Hepatitis B in Africa Collaborative Network. And this happened fairly organically. I mean, as I mentioned, as I was growing up as a researcher, I was part of several research collaborations, but I never really understood how these things started. So this was the first time that I was there at the beginning, and there was nothing special to it. Essentially, this group of people, we were always meeting at conferences, and we were always reviewing each other's papers and having intermittent calls about different issues in the field. And then at one of these meetings, I think we were at a dinner, we decided, all of our individual efforts, which you can see here, there was a great paper from the Gambia, there was a paper from Ethiopia, I was involved in a study from Zambia. And so we each were working in our own, in one country, and we were trying to influence policy that way. And we realized that if we worked together, we'd have more impact potentially. And so And so, yeah, we basically just started to have a series of calls to talk about what we would do. And the most immediate and logical thing to do was just to share and harmonize data because that wouldn't cost money to collect new data and would immediately potentially allow us to do new analyses that we weren't able to do on a single country level. We also undertook, together with about an overall group of about 20 to 25 HBV in Africa experts, we did a modified Delphi exercise of research prioritization. And this is, if you're not familiar with it, it's an approach to kind of build consensus among experts on which are the priority areas to focus on. So we came up with some research objectives that would guide us going forward. And you can see here that I think we were already clearly thinking about the need to characterize the natural history of hepatitis B in Africa using longitudinal studies. And number 2 and 3 and 4 were really practical. So just to develop more simplified treatment criteria and understand testing and treatment and how to integrate them into existing health systems in Africa. And then we started to get into the nitty-gritty of how to harmonize these different data sets. And so one thing that we did was to try to define, okay, what would consist of a cohort? What would a cohort consist of? And so we defined that as all people living with hepatitis B based on their being positive on the surface antigen test who had at least one visit for clinical care or a research cohort visit at a defined site in Africa. And so we kind of said, okay, this is what we define as cohort. And then our study design, we open this up to both retrospective and prospective cohort designs. And then at this point, as we were meeting and building our network, a lot of different groups wanted to be involved. And so we conducted a survey to identify the sources of cohort data. And so I just want to show you, I'm going to skip ahead. So these are just some of our sites that are collaborating. And so I just wanted to point out that we found generally 3 different types of data that would be considered cohort data. So first, there were at least 5 research databases, including the ones that were published. These are prospective cohort studies done in single countries or usually single hospitals. And they had, very relatively sophisticated data sets with minimal missing data and defined variables and code books, as you would expect. But then a number of sites wanted to participate using paper files at the clinic. So I don't think these paper files really exist anymore in the US. Maybe they do, but in Africa where I work, we still have a lot of clinics and hospitals that rely on paper files. And so you can see there that a number of sites had paper files and they said, we would like to include our patients and use their paper files as the data source. And then finally, there's an emergence of hospital electronic medical records in Africa, which is exciting. And you can see that some sites, in addition to paper files, like our team in Kumasi, Ghana, they shifted in 2017 from paper files over to a hospital electronic record. And similarly, Tanzania did the same, and I think one other site as well. So we identified these 3 different sources of data for the harmonization process. And then we had to think about how to fit them all together. And so what we did is for the paper files and those sites that were relying mostly on paper files, we created a REDCap database. And what the sites are doing now is once per year, they are taking the paper files and entering any new information from those files into the REDCap. And this is being supervised by a hepatitis B trained clinician. And then when the data reaches to the REDCap, which I'll tell you about in a second, a data manager who's hired by HepatiNet is performing quality checks and issuing out queries and making reports to try to augment the quality of that data. For sites that are using primarily a hospital electronic medical record, We now have worked with at least one site and now starting with a second to extract from the back end some of the electronic hospital records. And then our data manager would then need to recode the data according to our HepSaNet codebook. And then finally, on the right, for research cohorts that already have databases, it would just be a process of recoding and reshaping the data, which is more straightforward. And then, data sources from number 1, 2, and 3 are going to be appended. And then a massive data set would be created for analysis and dissemination. So I think I'm a little bit out of order here, but when we defined the term cohort within HepSaNet, we also came up with some very broad minimal requirements, however. So as you can imagine, there's a lot of excitement when we started because I think hepatitis B is very neglected in Africa. And so we were getting a lot of contacts from all over the region who wanted to get involved. And so we set a bar of at least 100 individuals with chronic hepatitis B at the site. We required the sites to have longitudinal data. We didn't really define that, except that, we just tried to emphasize that was important. They had to have a site PI who could be the focal person and demonstrated interest in hepatitis B. We asked them to meet certain regulatory requirements. So I think this kind of helped us to learn which sites were going to really participate and which sites were aspirational participants, but they didn't really have the ability to get a protocol through ethics and get permission to share the data. And then finally, we really encourage the cohorts to have at least one publication from their data before they join HepSaNet. So as for the regulatory requirements, we require that all the cohorts have to obtain and maintain ethical approvals at their country level. And for those who are using retrospective data, i.e. files, to enter into the REDCap, typically they're requesting a waiver of the need for consent, but the sites that have prospective research cohorts are obtaining informed consent for this process. The data to maintain confidentiality are being stripped at the point of data entry. So we try to remove the so-called HIPAA 18 identifiers, as I've heard that referred to. And so therefore, HepSaNet does not get access to any of this information. It's all kept at the site level. And then we do have a data sharing agreement that is signed by each cohort PI. So one of the features that helped us harmonize the data was this codebook. So we had about 8 calls. It was very tedious. We had about 8 calls with investigators from all over the region and some in other countries, in other regions as well, to look at the variables that we would try to collect. And we really wanted to have a limited number that were available at most sites, or the majority of sites. And also we wanted to find things which could be measured similarly across sites. So they had to be relatively straightforward. We put a lot of emphasis on laboratory and objective measures and less on subjective kind of survey measures, which may be implemented in different ways. And then we also wanted to make sure that almost every variable would be justified for a future analysis. So there were a lot of arguments about whether to collect certain variables because someone just wanted to collect as much data as possible, and others wanted to be more parsimonious and collect just what we needed. And so you can see in the codebook, we laid out we came up with variable names for each front end, the front and back end names, and we came up with the categories, and then we wrote out definitions. And then we have subsequently used this code book in order to train data managers and clinicians across the network. And so it started off as just a tool for the development of the REDCap, but then now has really expanded to also be used in training. And these definitions, we're using them to really try to reduce heterogeneity, which is our main problem as we go forward. And so the REDCap database is being hosted at a hospital in Addis Ababa, St. Paul's, and it has 4 forms. So we have one administrative or baseline form. This is done just once for each participant, whether they're in the study for 10 years or they have one visit and then are lost to follow-up. It doesn't matter, they get one. And then we have a repeating activity form. We call it activities. And that captures all of the clinical visit information, lab results, and radiology results, liver biopsies, CT scans, and all of the repeating activity forms are according to a date. And this was one thing that was innovative for many of our sites, that we're not used to thinking about things in terms of dates over time, because longitudinal cohorts are actually not very commonly used in Africa. And so we had to do a lot of training around this issue of why it's important to always keep the dates and make sure that they're accurate or relatively accurate. Treatment form we also used, and this again, every treatment had a start date, stop date, and then the type of treatment. So again, relied on dates. And then each participant was required to have one outcome form. And this is really where we're going to be used a lot in our analyses. So the outcomes that we defined, or trying to define, are going to be updated once a year. So we have, active, and we define someone in the cohort as active if they had at least one visit, lab test, or radiology test in the past 12 months, and then there's no evidence that they've had left the cohort. Transfer, we have a withdrawal, died, and then we have several other outcomes here. I think the most important outcomes to note are loss to follow-up. So we decided, and we'd love to get feedback from this group, we decided to have two loss to follow-up categories, because in our clinical practice, some patients, especially during COVID times, they were lost to follow-up from care. They were no longer coming to the clinic. But if we call them, they actually picked up the call. So obviously people are alive and out of care, but at the same time, we also know from other infectious disease cohort epidemiology that loss to follow-up can often be a proxy for mortality, especially if you're dealing with advanced HIV or TB, and hepatitis may be somehow the same. And so we have these two categories of loss to follow-up but known to be alive, or loss to follow-up and unknown if alive or dead. And for these four outcomes that I have, I've added the arrows for, we're having the sites update them year after year, because we recognize that sometimes patients are lost to follow-up and then they return. Similarly, someone who's active in care this year will maybe lost to follow-up next year. And so we want to allow people to come in and out of the cohort over time. And another important feature that we're promoting in HepSaNet for the sites is tracing. So tracing is the idea that if you don't know the whereabouts of someone, i.e. they're lost to follow-up, if you pursue them, try to find out what their real status is using their contact information, then you might actually be able to reclassify their outcome as died or lost to follow-up but alive, or potentially transferred. And so this area of tracing loss to follow-up was really well developed in the HIV field. And so we're really taking a lot of lessons from HIV epidemiologists in this area. And we're really promoting that, clinics should start calling their patients and following up them, even in visiting their home location if necessary. And most of these programs and clinics, when you enroll, they do collect what we call a locator form with some of your personal information as far as your phone number, and maybe your next of kin's phone number. And so we're really trying to support sites to do this to reduce our loss to follow-up. Here are a couple pictures. Here in the top left, you can see one of our trainings where we're going over about hepatitis B and the need for longitudinal cohorts. At the bottom, we had done a site visit to Tanzania to see how the hospital data looked and try to figure out how to harmonize it. And then up here on the top, these are some of my trainees. On the left, that's Enoch Siabala. On the right, next to me is Sydney Mpisa. And then Eddie Sinkala he's the head of Department of Medicine and University of Zambia. And so we were fortunate enough to sponsor our trainees to come to one of our regional meetings where we presented some data. I thought you might find this entertaining. working with paper files in Africa is a little bit shocking sometimes. But I'm sure there are files like this somewhere in the US as well. And you can see that, so you might be wondering, what is all this chicken scratch? And I can actually read this whole thing, and I can tell you it's also in French, not in English. Whereas, and so as part of our process, we had to, work with these kind of files and figure out how to transfer this data over to a longitudinal structure. You can see there in the top left that the clinician even has a nice layout of all the lab results over time. And so it wasn't that hard, but it's when you first look at this data, you imagine that you can't get anything out of it, but you actually can. And then here's another example on the right from Ghana, where, similarly, it was just underscoring the need to involve doctors in this process, especially the ones at the site level, and really make them the center of this project so that they could, they could be empowered to use this data better. So now within HepSaNet, we're starting to build up our data set, and we also now developed a process for analysis. So this is still actually in its infancy because the process of harmonization is still ongoing. And I'll just present a couple baseline analyses that we've done. But one thing that we have wanted to do, building on what I think a lot of other research collaborations do, is to have a kind of a concept sheet process. So if an investigator or basically anyone would like to analyze this data, because the data is really for Africa in general, and so we're not very exclusive in who should work with this data. We put forth a concept proposal process where an interested investigator would indicate, what they would like to study, what are their hypotheses, what data they need, how is it significant, who would they work with, and so this way we can keep track as this network expands. We can keep track of all of these analyses, and we can make sure that there's no duplication of effort as we go forward. So now I'll just present, I think I'll just present two of our baseline analyses. So as you can imagine, we were able to harmonize some of the research data a little bit quicker than some of the clinic files that are still being entered and hospital database records. And so we have done some baseline analyses of more than 4,000 patients. And so we actually also, as we started analyzing, we also wrote a cohort paper published in Epidemiology and Infection to just describe the HepSaNet origins and describe some of our protocols and procedure. And you can see that we had a good representation from Southern Africa, from West Africa, but I think we're still lacking in Central Africa, the Horn of Africa. We did have a site in Sudan that wanted to join, and they were just in the training process when the conflict broke out last year. So we're hoping that we'll get back on, be able to get back to that in the future. So this was one of our first research products. So in the field of hepatitis B, liver biopsy to stage the disease in the liver is very rare, and it's because it's expensive, it's painful for participants, and it has some sampling error. And so there's a blood test called the APRI score, which is recommended as an alternative to having a biopsy. And the World Health Organization had recommended this test score at a threshold of greater than 2. You can see in the dotted line on the far right. And so we have seen in clinical practice that it actually does not identify a lot of patients. And so using the HepSaNet baseline data, we were able to demonstrate that it had a sensitivity of only 19%. And, it's very specific, but had a very low sensitivity. And so we then proposed and we identified a different threshold that we now recommend, which is greater than 0.65. And that has a sensitivity which is better at 56%. It's still not perfect. And it only loses about 10% in terms of specificity as a test for cirrhosis. And so we published this last year, and it has already influenced Malawi to adopt it in their national guidelines. That's where I am now in Malawi, where I do some advising to the Ministry of Health. And it's also now being considered by the World Health Organization for its next revision of the guidelines. So I think there was big understanding now that using this guideline that the WHO recommended doesn't seem to work as well in Africa, and that a lot of patients were being overlooked. Then the second thing we did with our baseline data is to try to create a new treatment eligibility score. So we call it the HepatiNet score. So again, in Europe and in the US, the decision to when to give the medications for hepatitis B is based upon the viral load, and then it's based upon either the liver biopsy or some more sophisticated liver imaging tests. And neither the viral load or the liver imaging is widely available in Africa, particularly in outlying facilities. So where I usually work in Lusaka at the university hospital, because we have research funding, we have access to these tests, we have access to the biopsy, but most of the patients really have access to very minimal laboratory services. And so we came up with a test score, with a treatment eligibility score that relies just on 3 basic blood tests, the ALT, the AST, and the platelet. And these are tests which cost just a few dollars each. So while they're not going to be universally accessible, they're a lot better than doing an expensive PCR test. And so we came up with a scoring system which we thought that clinicians and program managers could use, just adding up the scores based upon the thresholds of these different laboratory tests. And that it had, relatively high area under the receiver operating curve. And so again, this is now being considered for use in certain countries as an alternative to the standard eligibility criteria. Okay, I just have a few more slides and then I'll get into question and answer. And so this is where HepatiNet is right now. So we have entered 1,800 individuals into our REDCap database. These are individuals who had their paper files entered. And not surprisingly, the current outcome for 70+% of them is lost to follow-up. So, and the average person time of follow-up before becoming lost is about 2 years. So this is, one important finding is that we're going to be seeing a lot of loss to follow-up as you might expect in this routinely collected program data or clinic data. And then in addition, we have the research data sets coming from about 2,500 individuals. These are from about 5 different countries. Those are being harmonized as well. And in the research cohort data, we have approximately 4 years of person time on average. And so overall, we estimate that we have more than 4,000 individuals and 10,000 person years of follow-up. And so we're really trying to emulate those hepatitis B cohorts in Asia that usually have more individuals and much longer follow-up. And so, but we have at least made a good start, I think. And we have a range of analyses planned once the data is more harmonized than it is now. And so, as you can see, we want to look at some very fundamental things in the field of hepatitis B. So the predictors of all-cause mortality, the predictors of HBV-specific mortality, predictors of loss of follow-up. Basically, none of these things have been done on a serious basis in Africa. And so as soon as we're hoping that once we analyze these, that this data will have widespread impact on our understanding of hepatitis B in Africa. We'll also be able to use our data to describe practice patterns, which may be interesting for future iterations of guidelines. For example, that I've seen that in some countries, they require the patients to come in every 2 months, and in other countries, every 6 months. And so we may be able to comment on whether more frequent visits are beneficial or not. In addition, we may see regional differences. In one of our baseline analyses, we found that viral loads were higher in one region and liver disease was more advanced in another. So there may actually be, because Africa has so much diversity, there may actually be regional differences in hepatitis B natural history. And then you can see we have a couple other future analyses planned as well. And then I should talk about funding. So until 2013, we had pretty much minimal funding for all of this. And it was really done just by the dedication of a lot of individuals and the the motivation to improve patient care. And so we're pretty proud of how far we went with just that. I think we received about $100,000 or maybe $200,000 from EASL, the European Liver Association, and the John C. Martin Foundation. And then I think having shown that our network could work together, could harmonize data, could get some high impact publications out, we recently received a grant from the John C. Martin Foundation for about 1.5 million. And so with these money, we're now trying to scale up our activities. So we've hired a 50% PhD statistician epidemiologist, Kalongo Hamusonde from Zambia, who trained in Switzerland. And we also have now established a contract with the MRC Gambia Data Research Unit, and they're providing more robust administrative and data management support. So this team will now be visiting all of the cohorts to continuously check data quality, reinforce trainings, follow up on certain queries. In addition, with these amount of funding, we're sending sites on the order of $20,000 to $30,000 a year to support their data entry, tracing activities, to attend meetings, to allow them to have some flexible funding, especially for those sites who don't have research grants. Yeah, and then we have some other ambitions as well, hoping to start sponsoring PhDs in the future, adding some additional analytical support in terms of statistics and epidemiology support. And then we also have ambitions if we can get additional grant funding to do in-depth studies. So there's a lot of interest in the virology, immunology, and liver disease aspects of hepatitis, but those are really, right now we're really focused on epidemiology. So, but this could be an add-on in the future. And so let me just talk about our limitations. So I think one thing which I'm sure was very clear to the epidemiologists who are listening is that the data are messy. So there's a lot of heterogeneity. And this will be a constant challenge because, of course, we have well-conceived prospective cohorts, then we have poorly resourced routine data sources, then we have some kind of a mix with therein. Some of the data are collected in hospital electronic records, some of them are collected on paper, some of them are collected on tablet. So there could be a lot of different heterogeneity. We have multiple languages, we have different cultural practices. So this is really something that we are very very in tune with. And so this is why we also really want to have strong support throughout the process from all of our sites, including from the PIs down to the statisticians, down to the data managers on the ground, so that we can at least identify the sources of heterogeneity so that those can be considered in our analyses. The other data-related issue is, as I mentioned, high loss to follow-up. So this is a reality of hepatitis B care in Africa. And so while I was initially disturbed by this, now I'm trying to embrace it, because I think that in the field of hepatitis B, we need to acknowledge this, and we need to use this data to call for stronger programs. So I think it was only through raising awareness of loss to follow-up that the HIV programs really developed all of their strategies that they now have to trace people, to incentivize, patient-centered care. A lot of these things really came from the problem of retention. And so I think that even though it may not look good, I think we're going to have to stand behind our loss to follow-up and really just try to describe it and try and use it for good. And then I think a final limitation that we're dealing with is the need for more African leadership. So in each country in Africa, as I mentioned, 83 million chronic cases. But in each country, there are only a handful of hepatitis B experts. So in Zambia, we probably have 10 experts on hepatitis B for 500,000 patients. And in addition, when you have so few experts, it's really unlikely that they will also be strong researchers or clinical epidemiologists. And so we're really trying to build our own experts up to lead this network. Right now, it has a lot of support from US and European partners, most of whom either live or have lived in Africa. But still, we recognize that many of the steering committee were not African. And so we want to hand over ownership in the future, so that it's, locally owned and managed. And so we're really not only trying to build up our own experts, but really just trying to be thoughtful about avoiding colonial practices. I'm sure some of you are well aware that a lot of research collaborations in global health in the past were really done in order to better the collaborator in the US or in the rich country. And, there were a lot of exploitative practices. And so we're really trying to make sure that we use as much equity in our strategy, and try to promote African ownership from an early stage. So that was my last slide, and I just want to say that I don't want you to think of me when you think of HepSanet. It's a huge network of people, and I'm just fortunate to be the one representing it here at UAB Epidemiology. And then, of course, we have core funding from the John C. Martin Foundation, which is really making a lot of things possible right now. Africa CDC is also a growing partner for us, and they have funded capacity building activities, especially for our junior scientists and data managers and clinicians. And Africa CDC is also funding some work in the policy arena, which can allow us to, use our data to make policy. Yeah, and then just thank you to all the collaborators across the network who really make this possible. So I'll just stop there. Thank you so much.